Okay, we're almost there. One more. So I'm going to talk about competing stimulus assessments, and then I'm going to talk about the whole admission process, like I mentioned, saving time for questions, because I know we didn't get to ask too many questions last time. So there are two different ways that you can do a competing stimulus assessment. There's the standard way, and then very recently, the folks at the Kennedy Krieger Institute came out with a new way to do a competing stimulus assessment called the augmented competing stimulus assessment. So I'm going to talk about that one briefly. It's very similar to the standard, just with some slight modifications, and then we'll tie it all together. So the handouts that's relevant for this training is the competing stimulus assessment session description that you guys have in your stapled packets. So Bruce's treatment plan. We've talked a lot about how we got to this point. So the overall goals for Bruce were to decrease his self-injury, decrease his aggression, decrease his disruption, increase compliance, and also make sure we're not providing any other potential reinforcers. So component 1, planned ignoring, addresses that last concern. We're eliminating any potential reinforcers. Spear prompting is helping us increase compliance and making sure that he gets work done. The differential reinforcement of alternative behavior, the last component, is also helping increase compliance. Functional communication with extinction is helping us to decrease aggression and disruption. So, what about self-injury? We're almost done treating all of his problem behaviors and meeting all of our goals for the admission, but we haven't addressed his self-injury yet, which, remember, is maintained by automatic reinforcement. So component number 3 at the bottom of the first page says non-contingent reinforcement competing stimulus, and that is what is going to address his automatic function. So before I talk about a competing stimulus assessment, I wanted to briefly talk about the concept of non-contingent reinforcement first. So alternative differential reinforcement are schedules of reinforcement where we're providing the functional reinforcer on some sort of a schedule. So when it's functional communication, we're delivering the functional reinforcer whenever it's asked for, or when they meet some sort of criteria after we do schedule a fitting. Non-contingent reinforcement can be used in treatment plans when we're delivering the functional reinforcer regardless of problem behavior. So non-contingent means that they don't have to engage in an appropriate response, they don't really have to do anything, but we're going to give them the functional reinforcer. So you can do this for social functions as well. We're going to focus, when we're talking about the competing stimulus assessment, that context of non-contingent reinforcement is for automatic functions, but you can do it for social functions as well. So for example, if you have Susan who engages in problem behavior for attention and you want to use non-contingent reinforcement, that just means that you would provide attention every so often. Maybe the treatment plan says provide Susan attention every 5 minutes. So that line of logic is that if Susan gets attention for free for not doing anything, she's going to not engage in problem behavior because she's already getting it. So that's how non-contingent reinforcement works in general. And if you know why the problem behavior happens, it's a very easy treatment component to prescribe. So if you're really, really short on time or the problem behavior is really, really severe, you can start with non-contingent reinforcement. If you need to provide the non-contingent reinforcement all the time, it's just a little labor intensive for the caregiver. So if you think about it for attention, if you're delivering, maybe 5 minutes isn't enough. You need to be continuously having a conversation with them for them to not be engaging in problem behavior. It's not very practical to implement. Same with if you have an individual who engages in problem behavior like Bruce to access escape from demands, you can just never tell him to do work and he probably won't have problem behavior. But that's also not very practical. And as I'm describing these, it might sound a little familiar, those procedures. That's essentially the control condition for a functional analysis. In the control condition for functional analysis, the way that we identify control is that when we're giving it to them for free, they should not be engaging in problem behavior. That's the control condition. And treatments could work the same way. That's non-contingent reinforcement. If I'm giving you attention for free, if I'm giving you access to escape for free, you're not going to engage in the problem behavior because you already have what you want. Those treatments just aren't always practical, and that's why differential reinforcement treatments are usually preferred in practice. So for the rest of this presentation, though, I'm going to focus on non-contingent reinforcement in the context of automatic reinforcement. So a competing stimulus assessment, the purpose is to identify stimuli associated with reduced levels of problem behavior compared to some sort of a no stimulus control condition when they are freely available. So one of Sungwoo's videos had a competing stimulus. Actually, if you remember one of the videos yesterday, the very last video he showed with the woman who engaged in like the very severe head-directed, she had all these little stuffed animals and the snakes. Those were competing stimuli. So she would rather engage with the item than engage in problem behavior. Those items compete with problem behavior. That's why it's called a competing stimulus assessment. So the treatment component is just called competing stimulus. The assessment is how do we identify those items. So how did Sungwoo's team know that the snakes would work or whatever other stuffed animals that she had? How did they know they would work? They did a competing stimulus assessment. So that's the purpose of this. So let's say we have all of these items and we're trying to see, do any of these items compete with Bruce's problem behavior? Would Bruce rather have any of these items than engage in problem behavior? So we have a stuffed animal. Some of you guys might have thought that that was supposed to be actual banana milk, but Tori, my staff, is the one who made your materials for you, and I told her to get a picture of a stuffed animal, and she just Googled Korean stuffed toy, and that's what came up. So that's actually a stuffed plushie. We have a stress ball, we have a poppet, we have a magazine, and we have a puzzle. So we're trying to see, will Bruce engage more with these items and engage in less problem behavior compared to some sort of a no stimulus control condition? So prior to beginning the assessment, you want to make sure they're seated at the table so that they can sample all of the items. Very similar to what you would do for a preference assessment. You're going to offer sampling first so that they know how to engage with the item. So for each toy, you can show them how it works, especially if it's maybe a toy that's battery operated and there's a button. So you can show them how it works and then let them engage with the item for a little bit before you start. We usually provide at least 10 to 30 seconds of access. Sometimes they might be done with it first. You might offer the, if this is, actually I have some sample materials here. Let me find my, okay, so we have the plushie. So let's say you're like, oh, hey Bruce, here's the plushie, I show you how to play with it, and let's say I look at it, I squish it a little bit, put it down, that's fine. We're not gonna force contact with it, this is just sampling, we're gonna make sure that they know how to use it. If they do really like it and they are playing with it, we give them like, 10 to 30 seconds before we move on to the other item. And here's an example of pre-session sampling.
Bruce, I have a squishy toy for you. Squeeze it, throw it. Whatever you want to do.
So that's very simple. So that one he knew how to engage with, so it was pretty straightforward. Here's another example. Oh, that was an example of if he didn't know what it was. So she gave some instructions on what you can do with it. This one is assuming that he knows what the animal is, so she doesn't give as much instruction in this video. Okay. So you have all of your items that you're going to evaluate, but like I said, you need to make sure that you include another condition in this, and that's the no stimulus control condition. So to run this condition, it's going to look very similar, if not identical, to your alone ignore condition from the functional analysis. So they don't have any other extra items, but you're just keeping track of how many problem behaviors they engage in. Because the goal for all the items is for them to not just engage with it, but for them to engage in less problem behavior. So you have to have a condition to compare to. And so that's the no stimulus control condition. So here's an example of what that looks like. So he has no items. And so this is the ignore condition. So we'll assume his self-injury is very severe. We can't leave him in the room by himself, like an alone condition. So Tori's present to block problem behavior. But she's not providing any attention or anything else. So then for each of the items that you include in the competing stimulus assessment, you're going to run them all the same, just with different items. So you're going to give them the item, they have free access to it, and then if you're taking data, if you're the data collector for this, you're going to keep track of both problem behavior and engagement. And so usually engagement, we track this by a duration of time. So let's say the session is 5 minutes. We'll keep track of how long they engage with the item, and then we'll just calculate some percent of session that they're engaged with the item. So let's say we're doing it for the squishy toy. And so Tori's really just there to block problem behavior if it happens. She's not going to socially engage in these sessions. If you were able to do an alone condition, like your baseline was an alone and the therapist doesn't need to be present, then that would be the case for all the test conditions too. So you would just leave the item on the table, exit the room, and then just keep track of how much they're playing with the item and how many problem behaviors are happening. So here's an example of an item where Bruce engages in problem behavior. So she's just there to block problem behavior. That's all she's doing. So these are how we summarize our results and identify if we found anything that's competing. So we have the percent of sessions. Those are the bars graphed on this primary axis. So we have 0 to 100% of sessions. So like I mentioned, we're keeping track of how long they're engaged with the item divided by the total duration of the session times 100 to give us this calculation. So we see the highest amount of engagement with the squishy toy and the least amount of engagement with the pop-it. So squishy toy seems like the best one so far. But what actually defines a competing item is how much it reduces problem behavior. Is it actually leading to a reduction? Is it actually competing? It's great that they're engaging with it, but we need to make sure that problem behavior is low. So on the secondary axis, on the other side, we have responses per minute of self-injury. And so that's the boxes. Those are combined target behaviors. That's what CTB means. So in the baseline, we saw the highest rates of problem behavior in the baseline condition. And so based on that, we have the 80% reduction line. So that's the goal. So if any of these items have a square below the goal, that means it's successfully competing, and we have a competing item. And we have one such item, which is the squishy toy. So we know that the squishy toy competes with Bruce's self-injurious behavior, and that's why it's in his treatment plan. So the squishy toy is to address the self-injurious behavior. So before we go to the role play practice, which I'll have you guys practice with the items in your baggies real quick, I just wanted to talk about the augmented competing stimulus assessment. It's very similar to the standard, except for that the session duration is a little bit different. It's more of a complicated calculation, but it's based on how much problem behavior they have in the alone condition from the functional analysis. The main difference is that in the standard condition, you saw Tori just blocking, or maybe she wasn't even present in the room. In the augmented, you block and redirect back to the item. So in the sessions that you just saw, Tori was just blocking and that was it. In the augmented, she's going to block and put his hand on the squishy toy and redirect him to the item. That's the main difference between the standard and the augmented. And so I have a video of that right here. Pretty straightforward, right? Okay, so let's practice that one real quick, and I'll walk around and answer any of your questions that you have about this. Okay, so we're gonna get back to the presentation. Before I go forward, I did want to, a lot of people had a similar question about types of items that you can use and different behaviors that you can use this for. So competing stimulus assessments, as I mentioned, are usually used to treat problem behaviors maintained by automatic reinforcement. But self-injury is not the only kind of automatically maintained problem behavior out there. So when you're doing a CSA, you want to make sure that the items you're included are at least somewhat related to the topography of the behavior that you're treating. So self-injury is a physical problem behavior, so that's why we're using physical toys. If you were to treat like maybe screaming, something vocal, something that we've done is an auditory CSA. So we try different kinds of sounds, like maybe classical music versus ocean wave sounds or white noise or pop music. So we try different kinds of audio sounds to see if any of those compete with their screaming or other kind of vocalization. If it's for elopement, like running away, you can use more physical activities, like maybe using a treadmill, an exercise bike, or maybe just going for a walk appropriately. You can see if any of those compete with that as well. So you don't have to just use physical toys like the ones in here. It should depend on the kind of problem behavior that you're treating. Okay. So, obviously, we can't just say competing stimulus is going to work. We have to evaluate if it's going to work. So we have our first baseline, and we see his self-injury is hovering around 3.5 instances per minute, which is pretty high. But once we give him non-contingent access to our squishy toy throughout the day, we see a lot less self-injurious behavior. And to make sure that it's our treatment that works, we're going to go back to baseline, and we see his self-injury increase. And then when we go back to treatment, we see that it decreases and we generalize. In this example for Bruce, we did not do schedule thinning, which means that he needs to have access to this at all times. And that's written specifically in his treatment protocol. So if he's going out into the community, he should have this. If he's going to his day program, he should have this. If he's home with his parents, he should have this. At all times, he should have this so that he's engaging with this and it competes with his self-injury. You could thin the schedule of reinforcement and make it less available. It's just not what we did here with Bruce. So we have all of our goals addressed, and now that we have done our competing stimulus assessment, we have also addressed our self-injurious behavior. So all the goals for the admission are addressed in this treatment plan. And so we did all those individual treatment evaluations. We did an evaluation for FCT. We saw that in our individual sessions. Those were about maybe 5 to 10 minute sessions. We did our compliance treatment evaluation with the token boards, and those again were like 5 to 10 minute sessions. We did our CSA treatment evaluation. So we saw in those individual evaluations that it worked. Now we need to make sure that the whole treatment plan works throughout the day. So to evaluate that, we are going to look at the graph that I showed you guys beginning of yesterday. So this is his baseline phase again. So this is how he does in general throughout the day for all 3 of his combined target behaviors: self-injury, aggression, and disruption. And we see that he's engaging in a pretty significant amount of problem behavior at baseline before we implement his treatment. Then with his whole treatment package, so that's the 5 components that you guys have in front of you. So we have planned ignoring, we have spear prompting, we have the competing stimulus assessment, functional communication training, and the other DRA for the token board, 5 components. And the combination of all 5 of those components did lead to a very successful admission for Bruce. We see that the entire end of his admission, he's having every day under the 80% reduction line, which is exactly what we look for. So now that we've talked about how the admission worked for Bruce, I'm going to talk about the typical course of admission in our clinic as a whole, so the timeline of how things work. So in general, we have a few phases of our admission. We have the admission process, so the referral and time on the wait list, and then they come in. And then the first thing we do is the assessment phase. Then they move on to the treatment phase, where we do those individual treatment evaluations. Then we generalize, we make sure that it works in the regular environment and with regular caregivers. And then they're discharged from our intensive services, but we continue to provide follow-up services. So I'll break those down one by one, starting with the admission process. So we have a referral process, and so to apply to be a patient in our center, they just apply on our website. So this could be, they could have referrals from any general stakeholders in the community. It could be from psychiatrists. We've actually had a lot of referrals from psychiatrists. It could be from, actually we've had some referrals from lawyers because the parents are trying to find anybody who will help their child in crisis. Maybe their child's about to be kicked out of their home, which has happened, their group home. And so they reach out to policyholders, and so they get in touch with lawyers, and then they refer them to our clinic. So it could come from anywhere. It could also be from the mom's friend. It could come from anyone. So the referrals come in through our website, and as soon as we get a referral, our BCBAs and myself review the referral information and determine if they're an appropriate placement for our clinic, because not all the times they are. So sometimes, because to be a patient at our clinic, you have to be engaging in significant, at times life-threatening, physical problem behavior. Usually typically all of our patients have at least an autism diagnosis. They could have more on top of the autism diagnosis. But sometimes we'll get referrals for people with bipolar disorder, who were maybe having suicidal ideation, and it is life-threatening, but it's not the kind of life-threatening behavior that we deal with, so we provide appropriate referrals for them, and they're just not an appropriate fit for our clinic. If they are an appropriate fit for our clinic, then they get put on a wait list, because we only serve 4 patients at a time. We're a relatively small clinic, and so we can't just take everybody as the referrals come in. I wish we could, but that's just not reality. So the time on the wait list, how we pick who the next patient is, we get this question a lot, even just yesterday and today, I got this question a lot. It depends on a lot of factors. So one factor is time on the wait list. We do try to go in order as best as we can, but that's not always possible. One reason that's not possible is the severity of the problem behavior, because we have to have a safe environment. If we have one patient who is very, very aggressive and requires a lot of staff, we try not to have 2 of those patients at a time because we don't have enough staff. If both patients were to have very severe outbursts at the same time, that would not be a safe environment. And so we might take somebody then who has more self-injurious behavior as opposed to aggression. So still somebody who's in critical need of care, but a different topography so that we have a good balance at our clinic and we're able to safely manage everybody's problem behavior in a worst case scenario. Another factor is, unfortunately, funding is a factor. New Jersey is one of the 50 states where we can bill private health insurance for adults. But sometimes they say no. And so while we do fight with the health insurance company, because we can appeal and we can fight them, I won't bore you with the drama of the American health system, but as we're fighting to try to get the patient admitted, we might take somebody else in the meantime, and then they might just be put on the wait list for a little bit longer until we figure that out. If the individual does not have private health insurance, the state could come pull through and give funding for the whole admission, but that takes a long time to go through the state and the government, and so they might be put on the wait list a little bit longer while we figure that out. So unfortunately, funding sometimes does play a factor. It's not ideal, but it is the real world that we live in. Let's see, another factor is staffing. If we're at full staffing, then we can take more severe cases, but if we are understaffed, which is also a real world problem, we might take somebody who's a little bit less severe or engages in a different topography of problem behavior. So all of these factors play into who's the next patient who comes into our clinic. Once we have somebody who comes in, we have the intake process. So before they even come to our clinic, we do several interviews with relevant stakeholders. So this would be with caregivers. If they live at a group home, we would interview those staff. If they have a day program, we try to interview those staff. We try to gather as much information as possible before they're even at our clinic. We do a few intake observations to try to see the problem for ourselves in the real environment. So I'll send my BCBAs and the team leader of the behavior technicians to their day program, to their group home, to their house, to get observation of what's happening in the real world before they come to our clinic. And then we have an intake meeting on the first day of the admission. We talk with the parents, talk about all the boring stuff and the consent forms and everything else, how to come to our clinic, what lunch to bring, all those tiny details. And then the patient starts and they have their first day of their admission with us. So the first part of the admission is the assessment phase, as I've mentioned. So upon admission, clinical assessments are conducted related to patient preference. So those are some of the preference assessments that we talked about yesterday. Adaptive skills and deficits, because they are with us for 6 hours a day, 5 days a week. So they spend a lot of time with us. And we don't spend all of that time doing intensive problem behavior sessions. So usually there's a break throughout the day. Throughout the 6-hour day, it's usually broken up into 4 different session blocks. The first 2 hours we call intensive behavior therapy, IBT. That's where we're really targeting the problem behaviors. And then we have 2 intensive adaptive therapy sessions, IAT. And usually lunch is in there, and we work on some sort of food preparation program, or maybe they have feeding difficulties, and we target that. And then we have another 1 hour long intensive adaptive therapy session where we work on replacement behaviors to try to increase appropriate behaviors to help them function in the real world. And then the last 2 hours of the day is, again, intensive behavior therapy. So 4 hours of the day is really targeting those problem behaviors. The other 2 is targeting replacement behaviors to increase appropriate skills. So that's how the day generally works. In the first about 2 weeks, they're in the assessment phase. And so a main purpose of this phase is to identify the potential causes of the challenging behavior. So that's the functional assessment. So we usually, after the assessment phase, we have what we call a steering meeting, which steers the admission, which gives us our tentative discharge date. So we determine how long do we think the admission is going to last. And this depends on several factors. One, is it socially mediated or automatically maintained? If we see an automatic function in the assessment phase, it's going to take longer. And we tell the caregivers that and relevant stakeholders. If it seems socially mediated, like we were able to do our function analysis very quickly, we know exactly why it's happening, it's something in the environment, we can treat it very quickly, usually. Another factor is comorbid diagnoses, which would come up in the admission process before they're even at our clinic. But something that's very common in our referrals is comorbid OCD, obsessive compulsive disorder. And if we see that, it's a little bit more difficult to treat than just the typical rituals characteristic of autism. And so part of the assessment phase, we're trying to determine, is it actually OCD or is it just the rituals of autism? Because those are 2 different things. If it's just the rituals of autism, it's a little bit easier to treat. But if they actually have a comorbid diagnosis of OCD, it might take a little bit longer. Same with intellectual disability. If they're very, very cognitively impacted, the admission might take a little longer. So during the assessment phase, we gather all of this information, and we come up with a tentative discharge date. We usually say the average admission is about 12 weeks, which is 3 months for the intensive admission. But that's just a very, very rough estimate. We have had patients who required less time. They had pretty easy socially mediated problem behavior. We've also had patients who were referred to us by very qualified clinicians who just didn't have the resources to do the kinds of things that they knew they needed to do. And so they already did a lot of great assessments and gave us really good information, so the assessment with us was shorter. And we also discharged them back to that clinician too. So if they have a good placement and a good clinician from the outside, those admissions can go quicker. Also, again, if it's very easy to identify socially mediated factors, those admissions can be less than the 12 weeks. If it's automatically reinforced, though, and we see a lot of comorbid diagnoses, it would be a little bit longer than those 12 weeks. So it really, really depends on the person, how long they're at our clinic. So I can't, if somebody were to ask me, how long is my child going to be there on the first day of the admission, I would say I'm not sure. The average is 12 weeks, but it could be less and it could be much longer. I'll know more when we're done with the assessment phase, and we talk about that at that steering meeting. So the assessment phase usually lasts about 2 weeks. Could be shorter, could be longer. And it depends on the results that we find. So we talked about the traditional functional analysis, but oftentimes we don't get clean data like we did with Bruce. What we get often is zeros in all condition. That's usually the first result that we get. And so that could happen for a few reasons. It could be because they don't know us, in which case we can do the caregiver FA, which I mentioned, or it could be very specific idiosyncratic functions. And so you just need to change your methodologies to try to figure out why the problem behavior is happening. We had one patient who we had to do, I believe, it was either 14 or 16 different kinds of functional analyses before we were able to identify why he engaged in the problem behavior. So his assessment phase was actually 3 weeks, because we kept having to change how we do it to figure out what those idiosyncratic functions were, and there were multiple of them too. So we would get a positive on one of the FAs, but we knew that that wasn't the only reason he was engaging in problem behavior. We knew there was more. So we usually do the assessment phase until we feel like we have a really good handle on why they're engaging in the challenging behavior. So it could take very short. It could take, I've done, before I had this job, I was working for an agency where the caseload was incredibly high. I didn't have a lot of time with all of the individuals. It was an adult service agency. It was more of the real world. I'm in the ivory tower, as we call it, at the IOC at Rutgers. But I've been able to do functional analyses in a 1-hour session for an idiosyncratic function. I had a really good idea of why they engaged in the problem behavior, and I just went to do a visit. And I had to be the therapist and the data collector myself. It was just me. I had no technicians, which is very common in the real world. So I was able to just do it myself and get it done in an hour, just from observation and talking to people before I actually went to do my assessment. So if you don't have a lot of time, I also recommend that. Maximize the time that you actually have face-to-face time with your client. Maybe do some research beforehand so that when they're there, you can really take advantage of that time. So you can get it done quickly if you want to, but at our clinic, they're usually referred to us for a reason. They're not a simple case. If they were a simple case, then at most of the other BCBAs in New Jersey could probably handle it. If they're a patient with us, they're referred to an intensive outpatient clinic for a reason. So then we have the treatment phase. So you guys saw kind of generally what we do in the treatment phase. So for Bruce, the treatment phase would have been the treatment evaluation for FCT. We would have done that first. So we would have gotten our baseline, we would have done our functional communication training, we would have taught him that response, then we would have put it into our treatment evaluation. The schedule thinning on his graph was only 3 sessions. That's usually many, many, many more sessions. As Sungwoo mentioned, he showed you a before and an after video, and he said there's a lot that happens in between, and that's very true. You usually have to modify your procedures as you go. Especially when you start schedule thinning, you might see problem behavior come up initially. Because if you think about it, you say, I need a break, please. You get it every single time. The first time you do schedule thinning, you're going to say, I need a break, please. And you're going to say, oh, not right now. I need you to do one thing first. And they're like, what? And then they engage in problem behavior. So it doesn't happen all the time. But when it does, we call that resurgence. And so there's actually a lot of really cool research coming out recently on how to mitigate resurgence. But it's not uncommon to see that happen, and you just have to plan accordingly. So that could take a long time. And also if you have multiple functions, which we usually do, because it's the intensive outpatient clinic, we usually have individuals who engage in problem behavior for multiple reasons, and you have to address all of those. So Bruce was a simple example of that. He had escape maintained problem behavior, and he had automatically maintained problem behavior. So for Bruce, we did the FCT, we did the treatment evaluation, we did schedule thinning, we did generalization. His compliance is low, so then we did a compliance treatment evaluation. And we also needed to address his automatic function, so we did a CSA, we did the competing stimulus treatment evaluation, and then we have to identify if that treatment package works as a whole. And a lot of times we can do multiple things a day. I mean, they are with us for 6 hours a day, so we could do some sessions of functional communication training, and then we can do some sessions of the competing stimulus assessment. We could do some sessions of a compliance treatment evaluation. We could also be doing skill acquisition program for feeding skills during the IAT. So typically in a day, the team sends out a summary email of what they've conducted, and they've usually done anywhere from like 6 to 10 different evaluations a day, multiple sessions of each one, because 6 hours is a long time, and we're maximizing the amount of time that they're with us. Because 6 hours a day does seem like a lot of time, but it goes by very quickly. And so we maximize that. So the treatment phase is doing those individual treatment evaluations to come up with that treatment package. Then we have the generalization phase. So generalization is hugely important. It doesn't matter if the treatment plan works at my clinic with my staff if it doesn't work in the real world. If it doesn't work when they're discharged, there was no point in the entire admission. So that's why this generalization phase is huge. So in generalization, we make sure that the treatment works outside of our clinic. So usually the first thing we do, our clinic is housed inside a community center. That's the building that's been showing up. I should have mentioned that. The building on my title slides is our center. So that's the Rutgers Center for Adult Autism Services Community Center. And then within that building is our clinic. So usually the first step of generalization is running it in the greater community center. And then we start going on community outings. Maybe we'll go grocery shopping. Maybe we'll go to their house. We do a lot of that. We go to their regular house in the generalization phase. So they're usually with us from 9 a.m. to 3 p.m. Sometimes we'll do whole days at their house. We'll just say, oh, no clinic today, we're gonna go to your house, and so that whole 3-person team, and even the BCBA, goes to their house to run sessions in the home to make sure that it works there. If they're in a group home, we go to the group home, assuming they let us come. Usually we work with very collaborative group homes, and that's not a problem. If they have a day program, we'll talk to them and we'll run sessions in the day program and we make sure that it works. A lot of times we'll start with our staff implementing it in that environment just to make sure that we're just figuring out if the environment is a generalization issue. And then at the same time, we'll be training the parents how to do it. So that's why I'm very lucky to have a big team. So while the team leader or some of the backup technicians are with the patient implementing the plan, the BCBA could be training the parent on how to do all of these components. And a big part of caregiver training, we use behavior skills training, which if you're BCBA, you might be familiar with that. It is the most effective tool, as evidenced by many, many, many research articles. It's the most effective tool we have to train people how to implement behavior analytic procedures. We did a little bit of it in this session. So BST has a few steps. Step 1 is providing the rationale for why we're doing this. So we explain to the caregivers, the results of our assessment phase. This is why your child is engaging in this problem behavior, and this is why we're implementing or recommending these procedures. We give a detailed vocal description with a written handout as well. So we usually have a handout, like a cheat sheet, of the treatment plan that we give them for them to review as we're detailing through the procedures. We then provide a demonstration. Usually it's a live demonstration with a confederate, so if I were to do it, I might have one of my staff with me and somebody will pretend to be their child and I'll be the caregiver and we'll show them how it works. We could also do it with the caregiver. If you're just by yourself, I'll tell the caregiver, they're very good at acting like their children. So I'll say, oh, pretend to be your child and I'll implement the plan. And usually when they do that, they throw you all kinds of curveballs. They try to be the worst form of their child to make sure that this plan works. And then you switch roles. Then you do the role play practice with them. So then you pretend to be the child and they have to implement it. And you usually take data on how well they're implementing it. It's called treatment integrity data. And we make sure that they meet mastery criteria before they're discharged. Because if the plan's not being implemented, it's not going to work. And we explain that to the caregivers. If you see a doctor and they prescribe a medication, you have to take the medication or you're not gonna get better. My treatment plan is my medication. You have to implement it and do it or it's not going to work. And so once you explain that to them, that it's very important that you implement it as written and you train them to mastery. We see good success with that. And we do that for not only parents, but regular service providers too. So the people at the day programs or the group homes or whoever is involved in their care. So we make sure once we train them that we observe them implementing that treatment with the patient. And we also continue to take treatment integrity data to make sure that they're able to do it correctly. And we're also taking data on how the child is doing, how the patient is doing with the caregivers. And so we make sure that it works, that the caregivers are able to do it, that the patient is able to have success in all these environments before they're discharged. Because if it does not work in the real world, the entire mission, there was no point. So this is a very, very important phase. Then we have the discharge process. So I mentioned the steering meeting at admission. That's where we come up with our tentative discharge date. We make sure that all caregiver training and generalization is completed. And then we have a discharge meeting with all the stakeholders. And we have more and more meetings as the discharge is approaching to make sure that we have systems set up for them post-discharge. And then they have their last day. Once they're done, it's not see you never. We still keep in contact. So we provide follow-up services. Excuse me. So the purpose of the follow-up services is to monitor the effectiveness of the treatment plan, make sure it's still working, and also to monitor treatment integrity, making sure those caregivers are still implementing the plan. So immediately following discharge, these follow-up appointments are more regular. So we provide, we go twice a week to their regular environment for 2 weeks, and then we start decreasing that to maybe once a week. Then we go to once every other week, then we go to once a month. And then once they hit a year post-discharge, we provide yearly consultation. And if we ever need to increase that, we will. If they are having some issues, we might bump that back up to a more concentrated dosage of follow-up hours. But generally, we fade our services, and then if they ever need us, they can contact us in the future. All right, and I did save some time for extra Q&A since I didn't in the last presentation.